A very good morning, respected judges and lovely audience. I am going to present my paper on exploring post-cataract surgery outcomes, the role of effective phacoemulsification time. Effective phacoemulsification time, or EPT, is the measure of the actual time ultrasonic energy is used during phaco, and it is implicated in various post-op complications. We wanted to assess the impact of EPT on BCVA attainment time post-cataract surgery, central corneal thickness, central macular thickness, and dry eye syndrome incidence. This was a prospective observational study, and prior approval from the ethics committee and written informed consent from all participants was taken. We assessed 65 eyes of 65 Indian patients aged 50 to 70 years with cataract as per LOCS 3 grading of nuclear pallescence 2 to 4 and nuclear color 2 to 4 grade. All patients underwent an uneventful phacoemulsification surgery via a 2.2 mm clear corneal incisions by a single experienced surgeon. We excluded patients with ocular conditions other than cataract, previous ocular surgeries, trauma, contact lens wear, long-term use of any medications, and any systemic diseases. A basic ophthalmological examination was performed preoperatively. Dry eye assessment was done by Schirmer's test and tear film breakup time. And ASOCT was done to measure baseline central corneal thickness and SDOCT to measure central macular thickness. Post-op assessment was done at day 1 week, 4 weeks, and 16 weeks. Schirmer's test value of less than 10 mm and T-BUT value of less than 10 seconds was classified as dry eye. IBM SPSS version 20 software was used for statistical analysis. EPT in our study ranged from 48 seconds to 1 minute and 54 seconds. Talking about post-op time to achieve BCVA, we divided our sample into 5 groups as per the EPT, wherein group 1 had the least EPT and group 5 had the maximum EPT. And we saw that group 5 took the maximum amount of time to attain their BCVA in the post-cataract surgery period, that is 5.1 weeks. We see an exponential increase in the time taken to achieve BCVA with this graph as the EPT is rising. So we concluded that longer EPT can delay visual recovery after cataract surgery. Talking about central corneal thickness, central corneal thickness increased for all patients maximally at day 1, and by week 4 it had reduced to the baseline values for all groups. However, the maximum increase was seen for group 4 and group 5. We see here in the graph that it's rising for all patients, maximum at post-op day 1, nearing to baseline values at week 4, and the maximum increase is seen in group 4 and group 5. So we concluded that longer EPT can lead to increased corneal edema in the early post-op period. Talking about change in central macular thickness, central macular thickness was maximum at week 4 for all patients. It narrowed down to baseline values, showed a downward trend at 16 weeks, and was maximally raised for group 4 and group 5. We can see in the graph maximum rise at week 4, that too for group number 4. So longer EPT may result in greater increase in central macular thickness during the early post-op period. Talking about correlation of EPT with incidence of dry eye syndrome, we saw that group 5 with the maximum EPT had the maximum incidence of dry eye disease at both 1 week and 4 weeks, that is 33% and 24% respectively. The graphs show an exponential increase in the incidence of dry eye syndrome as the EPT is rising. So we concluded that longer EPT may raise chance of developing dry eye syndrome both at 1 week and 1 month post-surgery. Our limitations were a small sample size and a relatively short follow-up period. We also hope to assess the role of EPT across different grades of cataract and pre-existing ocular and systemic comorbidities. In conclusion, I'd like to say that longer EPT is associated with a delayed visual recovery, increased corneal and macular thickness in the early post-op period, and a higher incidence of dry eye syndrome following surgery. Hence, it is important to minimize EPT to enhance and optimize post-op outcomes and expedite the visual rehabilitation. Thank you.
Which machine you are using?
Yes, sir.
Which machine you are using?
Which machine was used?
Sir,
That's
we
the
had the Infinity.
Pardon?
Infinity.
Sarah, I want to ask you, how are you measuring the EPT? Is time the only variable you're using in concluding to these remarks and conclusions?
Ma'am, just the time. We use the other parameters like were the same for all patients.
No,
ma'am.
my thing is ki there is a parameter called cumulative dissemination of
Yes,
energy,
CDE.
CDE, right? That takes into account the water going inside, the fluids going inside, and the total energy which has been used.
Okay.
So if it's a higher energy but lesser time, that will lead to more side effects, more increase in corneal edema. If
Yes,
you're operating in that dear chamber, you're making the PC safe, but that
Yeah.
might lead to corneal edema and increased CCT.
Yeah, ma'am.
So that those things have also to be taken into
Yes,
consideration.
ma'am.
Have you
Thank you.
mentioned the grade of cataract and the EPT?
Yes, sir. Sir, all patients had grade 2 to 4.
2 to 4 is a big range, because in 4 you may get more, you will
Yeah.
need more energy to.
Yes, sir.
So you
Dr.
cannot
Sir,
compare grade 2 cataract and grade 4 in the same group.
Dr. Sara, the plane of phacoemulsification is a very important criteria for developing whether it is done in the bag or pupillary plane or supracapsular. You have not mentioned about that factor.
Yes, sir.
Have you considered that?
Sir, it was done the same way for all patients.
That's right, but which way? Whether it was done in the bag
Sir, in the
phacoemulsification
bag, sir, in the bag.
or at the capsular level or
Sir, in the bag.
supracapsular level?
In the bag, sir.
And what about viscoelastic which was used? It was
Yes, sir.
visco which was used was common for all cases,
Yes, sir.
or it
Yes,
was
sir.
different according to the
same,
grade of cataract?
So same viscoelastic for all
And was it a
patients.
single surgeon who was?
Yes,
Yes.
sir. Yes, ma'am.
So
A
the
single
inter-surgeon
surgeon.
Variability
variability
is
also
not
not been taken into
Ma'am, it
consideration.
was a single surgeon who operated all the cases.
Yes, but there's something called inter-surgeon
Yeah, yes,
variability.
ma'am. That's one of the limitations. Yes, ma'am. Sure.
What's new in this study?
So it's a validation of.
We know that if you take more time, there will be more delayed recovery. So
About the dry eye you have mentioned, have you considered that the shimmers and the evaporative dry eye? Because evaporative dry is very common and the shimmers can be. uh,
Pre-operative dry eye.
hmm?
So
But
we
the
excluded
evaporative
patients.
dry is very common in our community. Have you considered that?
Sir,
And the interpretation of the shimmers test.
So we excluded patients who had dry eye pre-operatively.
Okay.
Yeah.
thank you.